you so much. And as I was just saying that the media is very important in research and the work that we do. We cannot be as effective as we should be without this work being reported. So normally what we do as scientists in Khamedi, one of the ways that you get promoted as a scientist is to do research and then to publish. Then we publish in what we call peer-reviewed journals. And most of the time, the public does not read these journals. So the way that you can reach the public is actually through your voices and through your presentation. So I'll take us through a presentation that I prepared on some of the work we do. And so the title is Mpox and other infectious diseases, research surveillance and outbreak response. And my name is Dr. Khamedi. I head the Center for Virus Research, where we do research on viruses of importance, including Mpox. So our mandate is to conduct health research, and Khamedi has been in existence since 1979, and we have more than 1,200 staff. And of these staff, about 700 are actually hired through the government, and then we have, right now we actually have more than 800 that are also hired through projects. Because apart from just doing research, we write grants, and those grants we take projects, and then we get people hired, and they do that work. We work with them. So we conduct health, medical and public health research, and we also advise the Ministry of Health on matters pertaining to health research, policies and priorities. Like during the COVID pandemic, we came up with a policy briefs that we submitted to the Ministry of Health so that they can convert these policies to help improve healthcare in Kenya and globally. We also have what we call incubation centers, where we do innovative research. Every year, Khamedi takes in more than 1,000 students on master's and PhD projects, and these students hone their skills in research. And apart from that, we also have what we call interns and another term I've forgotten. We have students who come on a short term, like for 3 months, and then we have those ones who come for a year. They stay with us, and then they find out whether these are the ones who have finished college. So they stay with us for 1 year, and then after that they can decide whether they want to do research or they want to go and do business and other things. And then last but not least, we work in disease surveillance and outbreak. So surveillance is actually going out to the field actively, looking at what is going on in the environment and picking pathogens and looking at them and seeing whether they are of outbreak importance or other related issues. And then now we also are involved in outbreak response, where we actually go out like right now during COVID time and then during Mpox. And one of the key issues about Khamedi is that we are strategically placed in the country. We are as far up as Mandera and as far down as Taita Taveta. We are also at the border in Busia. We are at the coast, and then we are here in Nairobi. So we are spread across the country, so that in case there is an outbreak, we are able to respond to it very fast. Apart from that, we are also doing research that targets different populations. Like the photo you see here, this is a study we are doing in Mandera, and we are collecting nasopharyngeal swabs from camels, because we discovered that there was a time we actually doing some surveillance work, and we collected blood samples, and we found people had antibodies against a virus called MERS-CoV. MERS-CoV is a sister virus to COVID, but it is a virus that is found in camels. So if somebody is exposed to, somebody has antibodies against MERS-CoV, then it means that this person is actually responding to that exposure. So we are actually doing studies in Marsabit to find out if MERS-CoV can be transmitted from animals to human beings, and then many other studies. So that's how we are placed in the country. And then strategically, in terms of capacities, we have highly trained and specialized personnel. We have molecular biologists, we have public health specialists, we have economists, and different cadres of staff who are able to drive the agenda of Kenya. And then we have what we call the state-of-the-art laboratories. We have what we refer to as biosafety level 2 laboratories. So if you go to a health facility like a health center, that is a level 1 laboratory. And then level 2 biosafety laboratory is the one where you have some practices that you engage, making sure that you don't contaminate yourself and also the environment. And then we have what we refer to as biosafety level 3 laboratories. These laboratories are highly contained laboratories that are maintained under negative pressure, meaning that if you're working in that laboratory, then the environment cannot get contaminated, especially if you're working with live viruses. Like there are some studies where we are looking at COVID, we are doing some phenotypic studies to look at some drugs and their capabilities to treat some of these viruses. So we do these studies in highly contained laboratories. And then we have highly specialized equipment that we use for doing this diagnostic work and also research. We have what we call sequencers. So for example, in the current outbreak of mpox, what we are doing is that we collect samples, we test them. Apart from just saying the sample is negative or positive, if we find out that the sample is positive, then we want to find out which clade of the virus is this, or which type of the virus. Because currently we have two clades of mpox. We have clade 1 and clade 1 and clade 2, and even among clade 2 and even 1, we have different types. So for you to be able to tell that, you have to sequence. So you sequence and then you look at the genetic material and then you're able to tell. And it is at this level that you can actually be able to develop vaccines, because vaccines are based on the genetic material of a given pathogen. And then we also have what we refer to as cell culture capacities, where we are able to do in vitro assays, that is, we grow these pathogens in the laboratory and look at them. We also have animal houses where we actually are able to do what we refer to as, like if you're developing a vaccine, you have to develop antibodies and test this in animals and so forth. And then we also have what we refer to as insectaries. So insectaries are laboratories where we grow mosquitoes. Like right now, there's a viral disease referred to as dengue fever. This disease has normally been prevalent along the coast and only at certain periods of the year. But now dengue fever is becoming endemic. So we are asking ourselves, how comes dengue fever is becoming endemic? Rift Valley fever is also becoming more prone. Like we are seeing more cycles of Rift Valley fever outbreaks, and we are asking ourselves, Rift Valley fever is spread by mosquitoes. Aedes mosquitoes. These mosquitoes, are they evolving? Malaria was normally not found in Nairobi. But currently we are also seeing malaria in Nairobi. So we are asking ourselves, are these vectors changing so that they are able to transmit these pathogens? So we keep these mosquitoes in the laboratories and under different conditions, and we are able to tell if they are evolving and changing to be able to transmit some of these pathogens. And then, as mentioned earlier on by my colleague, we also have what we refer to as production units. During the COVID pandemic, we actually came up with the sanitizers. We are also developing test kits, like the what we call PCR test kits for diagnostic purposes. So one of the key areas that I wanted to speak about today is surveillance and outbreak response. And we have a lot of infectious diseases that are out there. We have malaria, we have bacterial diseases that are caused by bacteria like TB. And one of the things that we are asking ourselves is that how comes we are getting more outbreaks? In fact, now you can start looking at, some people are saying there's a cycle that is like every 2 years, or even lower than 2 years, we will be having outbreaks. And so as Khamedi, we are involved in surveillance, so going out to the field and checking what is there, looking at pathogens that have potential capacity to cause outbreaks. And I was referring to MERS-CoV, the virus that is found in camels. Originally, it was found in Saudi Arabia and around these regions, but now we have seen that virus present in camels in northern Kenya and northeastern Kenya. Then we are also seeing antibodies to those viruses in human beings. So we are asking ourselves, if we are getting exposed, are there chances that we can actually get infected can this be the next pandemic? So one of the things we do is we do surveillance, and then we also respond to outbreaks. So we have viruses like SARS-CoV, the one that causes COVID. We have polio, which has been with us. So in case you find a single virus of polio in Kenya or any place, it is an outbreak, because polio is supposed to be eradicated. But one of the things we also found is that the vaccine that people are given, some of them actually they mutate and actually cause polio. So we also are doing studies on polio. We have laboratories that are WHO accredited that are looking at polio. We have labs that look at viral hemorrhagic fevers like respiratory fever, yellow fever, dengue fever, chikungunya, and among other viruses. We also look at bacteria. And so this is just a photo of some of the viruses that we are looking at. So in terms of the historical support we have been providing to the government of Kenya, we've been looking at different pathogens over many years. We have been looking at Rift Valley fever, and we have been looking at viruses like chikungunya, dengue fever, Marburg. Marburg and Ebola belong to the same class and are some of the most dangerous viruses, because the mortality is almost 100%. And then we have viruses like polio and the other causes COVID. So over the years, we've been looking at these viruses, and something that is very key for us is surveillance. So surveillance is an alarm system. So out there in the communities, if you see something that looks different, or you see somebody has symptoms that look different from other infections, then you ask yourself, what is this person exposed to? And so we have facilities across the country where we do active surveillance, and also we respond to the outbreaks. Next slide. So this is just, you may not see this very clearly, but it's just a slide that shows over the years the viruses we've been responding to, like dengue fever, yellow fever, chikungunya, and the areas where we've been responding to these viruses. And as I was saying earlier on, that we are seeing these viruses becoming more and more prevalent. And because of issues like climate change, we think that these viruses may become more and more common. And for you to be able to detect these viruses, we need very high quality diagnostic kits. And I'm happy that my colleague has mentioned here that they are developing kits. And one of the things we've been asking ourselves, like right now, Mpox is on the spread, and we're asking ourselves, serologically, we don't have like antibody tests that are very specific for Mpox, and therefore we mentioned about developing an antigen test, and we think that will be something very special for especially doing surveillance in the communities. The importance of surveillance, like there was a time when we had the COVID outbreak, we went to Kibera and we actually tested the community there, and we actually found a significant proportion of them have been exposed to COVID. And so the questions we were asking ourselves is, how comes the exposure and the disease itself, they're not related? So that's why we do research, so that we can answer some of these questions. So I already talked about the COVID response of 2019, that happened in 2019-2020. We were at the forefront of doing this, and the Khamedi labs where I work were the first labs to start testing for COVID. And unfortunately, we even lost some of our colleagues in the process of doing that. So this, in the line of duty, it's a sacrifice that people make, especially when you're looking at something that you don't know what it is. So we used to work around the clock, 24 hours, making sure that by morning we have generated results for the previous day, so that in the afternoon there's a briefing from the Ministry of Health saying what is going on, what have been seen. So that most of that information was actually being generated from Khamedi. So now talking about the Mpox outbreak, is that this virus also is a sister virus to smallpox. I know Gen Zs normally say because a Gen Z will say they belong to the same WhatsApp group. Smallpox and Mpox are very closely related. And so scientists are thinking that when smallpox was eradicated, we stopped doing vaccination. And the opposite effect of it is that mpox, which is closely related to smallpox, became more prevalent, because the first cases of mpox were reported in around 1958, and this was in research animals, research monkeys. And then after that, in the early 70s is when we started seeing cases of mpox in the wild, and spread from animals to humans, what we refer to as zoonotic spread. And then after that, in the early 2000s, we saw an outbreak of mpox in the US, around people having sex, men who have sex with each other. And then in Africa, in May 2022, we had cases of mpox. Although that time when we were doing surveillance work, we did not come across a positive case of mpox in Kenya. And then around July 2022, we saw multi-country spread of mpox, and then it died out. And then this year, we have started seeing mpox coming in a big way. And what is different now is that the mpox that was there in 2022 was mainly what we refer to as clade 2, that is found in Central Africa. But now we are seeing mpox that is clade 1, and especially clade 1b, that is more dangerous than clade 2, that has also been reported in Kenya. And so the question that scientists are asking themselves, what is causing these changes of the viruses? And I just want to report here that you might have heard, we had one case of mpox that was reported in Taita in early August, and this was a person who had traveled from DRC. And yesterday we also tested a case of somebody who had traveled from DRC who had come to Kenya, and he was actually isolated in Busia. And I think that's the second case that the ministry has reported today of mpox. And so we are working to make sure that we are able to control this virus. So we just have some data that I got from WHO that shows the countries that are mostly affected by mpox. DRC is at the top there. And what I say about DRC is that mpox is thought to be endemic in DRC and some parts of Central Africa and West Africa. And most of the cases that we are seeing, that we are reporting in Kenya, are people who have traveled from outside the country. So our biggest fear is that we hope that we will not have what we call community spread in Kenya, where now the virus is spreading from one person to another, people who have not traveled out of the country. And so I know at that time when this slide was presented, we had one case, but today another case has been reported. Yes. And this is just a picture of the epicenter of the virus. So the virus is actually mainly around West Africa. The red part shows the cases that are reported in 2024, and especially the ones that are active. And as I said, most of these cases, like the ones that are the ones in red are mostly cases of clade 1 virus. And the affected countries are Kenya, Burundi, Rwanda, Uganda, DRC is at the top, and other countries. So the chances are that this virus will continue spreading, and that's why the WHO has recently, and Africa CDC announced the virus to be a public health emergency of international concern. So when a disease is announced that way, then it means that we have to put in place measures to control it. Funds have to be allocated for vaccine development. We are supposed now to start closely monitoring the situation so that we reduce the spread of the virus. So these are just the clades that I was talking about, clade 1A and 1B. So clade 1B is the one that has been also been reported in Kenya. And this clade is thought to be more dangerous than the clade 2 that I talked about. And most of the cases are actually, like in DRC, it is thought that the initial cases were from animals to humans. But now we are now seeing human-to-human spread of the virus. and it seems to be following, especially truck drivers are the ones who are currently spreading the disease. But if it's not controlled, we think that with time it will start spreading now from within Kenya and among people who have not traveled out of the country. And this is a picture to emphasize the one in blue shows the clade 1B, the one in green is clade 1A, and then the one in yellow is clade 2. And then the blank spaces are places where mpox have not been reported. So if you are an epidemiologist, you can say that this is a great opportunity for us to control the virus. So when you hear that vaccines are being hoarded in other countries, because there are countries that have these vaccines based on the previous experiences they've had, but those countries do not have an active spread of the virus. So this is the time that we need to have vaccines given, especially to countries like DRC and these regions where the viruses are spreading, because that's where the vaccines are needed. And that's why we normally say that it's important that we recognize that we're living in a global village so that we can ramp up vaccine development. And I just want to mention here that one of the things that we have been saying is that we don't seem to have learned a lot of lessons from the COVID pandemic, especially as a globe, because during the COVID pandemic, for a long time vaccines were not even critical needed. And then after that, they were sent out. And then the same thing is happening currently. There's very little funds that are allocated for surveillance and outbreak response. We need more facilities to be set aside where people who are suspected cases can be isolated and so forth. And diagnosis is very important at this point in time, and that is accurate diagnosis. And one of the challenges we are seeing is that we may be having improper sample collection, so the cases that we may be seeing may be lower than what we would expect because probably the sample collection is not as good as it should be. And then secondly, we also need to develop networks where we can be able to report, especially as neighboring countries, Kenya, Uganda, Tanzania, and the other countries. We need to have now a very concerted effort in terms of responding to this outbreak. So this slide talks about the key issues. We currently don't have a clear understanding of the epidemiology in terms of transmission dynamics in other countries. We just have information that it is spread by touch and so forth, but there could be other levels that the way the virus is being spread. And then the data collection and analysis and reporting across different countries may not be as accurate as it should be. And then given the stigma, for example, you had rashes, what would you do? Would you go to a health facility or would you hide in the house? And just imagine if that happened to you. So there are also issues of stigma. Many people, even in DRC, that has been one of the biggest challenges in control because of the stigma related to the virus. And then I'll talk about opportunities. Opportunities like for us in the laboratory, we are thinking about scaling up and making sure as many facilities as possible can test for this virus, so that we have what we refer to as a quick turnaround time for generation of results. And then using the novel techniques to be able to sequence the virus and generate result information that is very important for our use. And then alignment as countries that are being faced with this pandemic to make sure that we work closely to address the pandemic. And then designing and implementing cross-country epidemiological studies to understand the transmission dynamics of the virus. Because if you understand the transmission dynamics, then you can be able to control it. When HIV came about in the early 80s, it was recognized among very few populations, among men having sex with men in the Western world, and in Africa it was also the truck drivers were the key people who were spreading the virus. And at that point, if certain things had been done, they probably wouldn't have had that epidemic. So even in mpox, we think that as governments we need to work really closely to address that. So I'll conclude by just talking about our response as Khamedi. We are working closely with the Ministry of Health as part of the rapid response team. So daily we are having meetings, we have laboratory personnel, we have epidemiologists who are meeting to discuss on how we can develop job aids we can share with health facilities, and information materials that we can share with you people so that you can also report. And we are also using avenues like the radio. The other day I was at KBC Swahili, KBC English, and also KBC Ingo FM, telling people about mpox. So those are things that we can work together on. And then we're also supporting about the testing. And I'd say, like the case that was reported, this recent case was done, and the testing was done in Kisumu, and Kisumu is very close to this year. So instead of sending a sample to Nairobi, we have a lab in Kisumu that can be able to test. Then we have research initiatives and opportunities, both local and international, where we collaborate with partners to be able to have a concerted effort in addressing mpox. And then continued surveillance for emerging and re-emerging pathogens, so that we can be able to be at the top of the game, so that instead of being reactive, we are proactive, so that we are able to see what is happening in the environment, because before it becomes something of public health concern. Then maybe the last bullet I should have put here is engagement of the media in a more proactive way. We would like to work more closely with you to report these stories in a language that people can understand. And personally, I'm looking forward to a time. The day we were having this presentation on Citizen for mpox, and the slot that we were given was like about 2 minutes. And then that was the time that we were having athletes coming from the Olympics. And an athlete was allocated about how many minutes? So you can see, and we have people are doing cutting edge work like him. And there's a challenge I'm sure to you journalists. Yeah. Sometimes the story may not be as sweet or as big or as, but it's something that, imagine calling him to tell, like me, I work in the research field, and what he has said today, and you'll be hearing it for the first time. You can imagine if that's the case. So the media has a very big role to play in terms of making sure that people hear. Because what would be wrong if you gave somebody 5 minutes to talk about mpox and not just 2 minutes? You know, we talk very far. In fact, they even tell me, our time is very, please cut it short. So, you know, when we ask ourselves, okay, maybe, and maybe that's even for the government, that's how the priorities are probably. Maybe our priorities are based on how we package our information. So I'll conclude by saying that we can make things better by creating materials, by having features that are well written by you guys so that people can read them, put them on the front page, not on the back, so that people can read them and say that these are the things that we're doing. I don't know if there's another slide after that. So that's the last slide, just to thank you for being us.